This video demonstrates transposition of a brachiobasilic fistula to be used for dialysis access. Brachiobasilic fistulas after creation most often require a second stage procedure which can include either a transposition or superficialization. This allows the basilic vein to be mobilized from its medial location in the arm to a central or lateral position and hence easier access during dialysis. Ultrasound is used to mark the location of basilic vein in the arm. This is followed by making an incision on the medial aspect of the arm centered over the basilic vein. Dissection is carried through the skin and subcutaneous tissue. Adequate exposure is a key for exposing the basilic vein. Self-retaining retractors as galpies are placed to expose the basilic vein, allowing us to further continue our dissection more proximally towards the axillary vein. For adequate exposure, a self-retaining retractor is then placed towards the proximal anastomosis of the basilic vein and brachial artery, and dissection is continued towards the proximal anastomosis to dissect as much length of basilic vein as possible. Next, the vein is marked to allow for proper orientation during tunneling and to prevent twisting of the vein. Side branches are meticulously dissected free and are then divided. This is done throughout the length of the basilic vein. This is followed by placement of a clamp near the anastomosis between the brachial artery and the basilic vein as distally as possible to allow for adequate length of the basilic vein to be harvested. Once the basilic vein is transected free, the stump of this basilic vein is oversewn with a 5-O-proline suture. Full transposition of the basilic vein like this with division and re-anastomosis allows preservation of all the nerve branches. And an adequate tunnel configuration is then determined. Counter incision site for tunneling purpose is marked on the skin. This is followed by exposure of the brachial artery in the medial arm. Dissection is continued until the brachial artery is dissected free from the surrounding tissue. Next, a counter incision is made on the lateral aspect of the arm. A superficial subcutaneous tunnel is then made, superficial enough to allow for easier access to the fistula and deep enough so not to compromise the blood flow to the skin. Towards the incision, this tunnel is deepened and dissection is carried around this tunnel to prevent compression of the basilic vein with transposition. Next, the basilic vein in its proper orientation is pulled through this tunnel. The vein is then distended, making sure it's not twisted or kinked. A cruciate-shaped incision is made in the soft tissue. This is done to prevent kinking at the transition of the basilic vein from anastomosis into the tunnel and to ensure that the fistula is superficial to Scarpa's fascia. Shown here is the tunneling of the basilic vein towards the brachial artery, making sure that the vein is not twisted or kinked during this process. Heparinized saline is then flushed through the basilic vein, making sure it's not twisted or kinked. A venogram is generally performed prior to construction of an anastomosis to make sure there are no twists or kinks. Demonstrated here is the venogram with no twist or kinks in the outflow of basilic vein. This is followed by transection of the basilic vein to a healthier segment. Clamps are then placed on the brachial artery. Distal clamp is placed first, followed by the proximal clamp. An arteriotomy is then made in the brachial artery using an 11 blade. This arteriotomy is then extended with pot scissors. Stay sutures are then placed in the brachial artery. This would allow for adequate visualization during creation of our basilic to brachial artery anastomosis. This is followed by creation of an end-to-side anastomosis between the brachial artery and basilic vein using a 6-O-proline suture in a running fashion. Once the anastomosis is completed, the venous clamp is removed first. This is followed by removal of the distal brachial artery clamp, followed by removal of the proximal clamp while making sure that the distal brachial artery is clamped. This is done to prevent embolization towards the hand.